Hello everyone. Uh, Welcome to the webinar on dental management of diabetic patients. Now, diabetes mellitus is considered as one of the most globally life-threatening disease, which is absolutely chronic in nature. And as you all know very well, that diabetes mellitus is of three types: type 1, type 2, and type 3. Type 1 diabetes mellitus is called as the juvenile diabetes mellitus, which is because of the insulin deficiency. Type 2 diabetes mellitus, which is called as non-insulin dependent diabetes mellitus, which happens in the adult, which is also called as an insulin resistance type of diabetes mellitus. Then you have got type 3, which is gestational diabetes, which happens in second to third trimester, which is very rare part, but then seen during pregnancy. And it is all because of the hormones which are released from the placenta and which interfere with the insulin action, that which is called as a gestational diabetes. Diabetes is given a very popular, or I should say a very important disease factor. And when you consider the complications of diabetes, which are actually classified into acute complications and chronic complications, you have got various complications of diabetes, which could be on heart or cardiorespiratory, renal, ocular, nephropathies, neuropathies, and most important, hypoglycemic or hyperglycemic coma, or a non-ketoic hyperosmolar diabetic coma, and again lactic acidosis. But the most important and recently considered complication of diabetes mellitus is none other than our dental disease, which is called as a periodontal disease. So periodontal disease is considered as the sixth complication of diabetes, which was accepted by the American Diabetic Association also, and it was accepted in 2005 itself. But then now it is considered as one of the most important complication. When you compare to systemic diseases, even this is considered as one of the complications for diabetes mellitus. Now, the fasting glucose levels, when we consider diabetes, we have got normal glucose level, which is 70 to 99 in fasting condition, which is considered as milligrams per deciliter. Then you have got impaired diabetic control, which is pre-diabetic condition, which is 100 to 125 milligram per deciliter. And then more than 126 per deciliter is considered as a diabetic state when you compare the fasting glucose levels of a patient. Then there is something called as oral glucose tolerance test, which is done 2 hours after giving 75 grams of glucose drink. In that you have got normal levels, which is 140 milligram per deciliter is normal. That means if it is impaired or pre-diabetic condition, it is called as 140 to 200 milligram per deciliter. And then if it is a diabetic, then it is above 200 milligram per deciliter. See, oral glucose tolerance test is nothing but a postprandial sugar level, but which is professionally called as oral glucose tolerance test. Now, we don't consider these tests as very important because you have got other tests also, which we'll discuss later. So dental therapy has some limitations when you have an undiagnosed diabetes or a poorly controlled diabetes. There are definitely some considerations which has to be done. You have got, if a patient is suspected of having an undiagnosed diabetes, then what do? We consult the patient's physician. Maybe you have a doubt that patient has the diabetes. You analyze or send him for the blood investigations for glucose evaluation, which is fasting glucose, which is casual glucose, and postprandial blood glucose. You rule out the acute orofacial infections and severe dental infections. The primary test which you actually use to assess the glycemic control in a non-diabetic individual is none other than a glycosylated or a glycated hemoglobin assay. Now, this is something very important to be considered, that it is called as a glycemic control evaluation, which has to be done. This assay will reflect the glucose concentration over the preceding 6 to 8 weeks. That's almost, you can consider 1.5 to 2 months, and then may provide an indication of a potential response to a dental therapy. Now, glycated hemoglobin assay, when considered normal, is less than 5%. You can say 4 to 6%. Then you have got less than 7, which is good diabetes control, 7 to 8, and more than 8%. Now, what is the importance of this? Now, you all know that the basic hemoglobin which is present in our adulthood is hemoglobin A. The other forms are abnormal, HbF, HbA2, and HbA1c, which is considered now. So HbA1c, there's a very important question which is asked very frequently in exams, that what is the difference between HbA1 and HbA1c? HbA1 is the normal hemoglobin which is actually present in all our human beings. We have normal hemoglobin and our chains are alpha 2 and beta 2, being very clear and being very specific. Whenever there is a glucose residue which is attached to a beta chain, which is normally present also in our circulation, which is less than 5%, there is a good diabetic control. So when HbA1c percentage is found to be more in your circulation, that means that you are a diabetic, and which gives you a prior history also that you had a poor diabetic control or poor glycemic control. That is the difference between HbA1 and HbA1c. Next. Now, when the patients are with relatively well-controlled diabetes, when I say well-controlled, it is less than 5%, or you can say 5 to 6% is normal. When controlled, you can say 6 to 7%. They usually respond well to a therapy. Poorly controlled patients, like more than 10% HbA1c, often have a very bad response, especially post-operative issues, complications, and very less favorable long-term results. When we consider this, we especially talk about the periodontal infection, which may worsen the glycemic control and should be managed aggressively. That means there's always a connection in the periodontal infection and glycemic control and the management. Diabetic patients with periodontitis should receive oral hygiene instructions for us as a dentist, and you should always make sure that a patient is diabetic and has a periodontal disease. Then oral hygiene instructions, mechanical debridement, SRP, regular maintenance, and SPT is one of the most mandatory things. When possible, HbA1c of less than 10% has to be maintained if you are establishing the patient for a surgery. If the patient has a very poor control, you can avoid surgery, which we say as we defer a surgery. You should always do a procedure in uncontrolled diabetes only if it is an emergency. Otherwise, it is always preferable to defer the patient if it is an elective dental care. Penicillins and macrolides are the often prescribed antibiotic. This is also one of the important questions, that which antibiotic is preferred as a prophylactic antibiotic for diabetic individual in dental treatment or extraction or periodontal surgery. Answer is penicillins and macrolides. You need to always recall the patient and check after the active therapy whether what is the response of the tissues and the patient towards our treatment, which has to be noticed. Many diabetic patients today use glucometers for immediate blood glucose self-monitoring. So you have to make sure that patients are always carrying their glucometer, or there's something called as the glucose watch or a pocket watch where they have this type of maintenance of the glucose. And diabetic patients should be used or should be asked whether they have glucometers. If they have, they should carry, because there's a particular level, because they have some other level which they are having, you have some other brand, so there will be a mismatch. So if they're having it, let them carry it, and you have to utilize it in the dental office. So what guidelines will you follow if you are actually following the management of a patient who is having diabetes? The guidelines which you will always follow is the patient should be asked to bring their glucometers to dental office, which is the first thing. Patients should check their blood glucose before any long procedure to get a baseline level. Patients with blood glucose levels at or below the lower end of a normal before the procedure have a very high risk of becoming hypoglycemic intraoperatively or postoperatively. So it's always advisable to have a patient consume something, especially carbs, before starting your treatment. They have to make sure that. For example, if you measure the glucose of a patient, whether it be diabetic or non-diabetic, and you feel that the pre-treatment glucose level at the or in the dental office before you start up your treatment is 70 mg per deciliter, this is the normal range, you better give him carbs in the form of 4 ounces of juice pre-operatively and start your treatment just to prevent hypoglycemia. This is even for a normal individual also. There are normal individuals who come and say, I didn't have my breakfast, I didn't have my lunch, and they come and you feel doubt on them, especially female patients, anxious patients. So you need to understand that. And if pre-treatment glucose is high, you cannot do anything. You have to just defer the patient, postpone the appointment, send it to a diabetologist, and look after it later. Anytime during the treatment you feel that patient is showing symptoms of hypoglycemia, then you need to immediately measure the glucose level. The most common issue what happens in dental office for a diabetic individual who is especially taking insulin, which are type 1 diabetic, is hypoglycemia, which is also called as a hypoglycemic shock, which happens in a dental chair. It is always associated with the use of normal insulin or a numerous oral agents. Oral agents means, I mean to say, hypoglycemic drugs like sulfonylureas. In patients receiving conscious sedation, the warning signs of the impending hypoglycemic episode is masked. That time you have to measure glucometer. Take a glucometer. We declare a patient to be hypoglycemic when it is less than 60. So 70 is our border. If it's 70, you take a prevention by giving something. If it is less than 60, patient goes into hypoglycemia. And in patients with poor glycemic control, who actually have a prolonged hyperglycemia also, a rapid drop can happen even at 60 plus. That means patient who always has 200, 250 as a sugar, their hypoglycemic level can be 100 also. So you just cannot blindly believe that if it is less than 60 only, patient will fall into hypoglycemia. If patient is already an uncontrolled diabetic and you have made him control forcefully and you are doing an operation at 180, so patient may go into hypoglycemia at 100 also. So you need to take care of that. Periodontal treatment often can be timed to avoid peak insulin activity, especially when the patient is taking multiple injections, suppose doing full mouth flap or two things or a donor side recipient zone each day. In each case, it is difficult, and if not impossible, you have to avoid the insulin activity, the peak activity. Checking the pre-treatment glucose with the patient's glucometer, checking again during long procedures, and again at the end of procedures is the best thing you can do for a patient. If hypoglycemia occurs during dental treatment, therapy should be immediately terminated. If glucometer is available, you have to always make sure that you are evaluating the glucose level. What do? This is one of the most important slides which you all have to concentrate on. Patient goes into hypoglycemia, but patient is conscious, patient is responsive, patient's eyes are open, talk to you, but patient says, I'm having dizziness. The first thing patient says, dizziness, headache. What will you do? You give 4 to 6 ounces of juice, 3 to 4 teaspoons of table sugar, your regular sugar, or a candy with a 15, which normally has a 15 grams of sugar. Practically, do you think that you can measure all these things? You cannot. You don't know what is, except sugar. So what we can have, best thing in our clinic as a dental office, is a chocolate. Just giving a patient a regular chocolate or a candy to chew is enough for sometimes. You feel that patient is conscious, but patient is not comfortable taking something or opening the mouth or just not able to have food or a drink by a mouth. Or if patient is sedated and not responsive to you, but patient is conscious, the best thing you can do. See, when patient is sedated and all, most of the time they are conscious, semi-conscious. You have to go for 25 to 30 ml or 50% dextrose IV or 1 mg glucagon IV or IM if you are not able to get IV because patient is restless. I hope these things are very clear. 15 grams oral carbs in these forms, dextrose IV or glucagon IM. Dosage is very important and very, very important for exams, whether it is a Viva exam for your practicals or for your any entrance exam. These values and these concentrations are very important to be considered. The 15 grams of oral carbs, 25-30 ml or 50% dextrose IV, and these are important to be considered in your dental kit. Because dental therapy may render patient unable to eat for some time later. Suppose you have done extraction. Suppose you have done flap surgery. Suppose you have done episectomy or an oral surgical procedure. Do you think your patient can have the food immediately? No, because you ask the patient to bite on a cotton for half an hour, don't spit for 1 hour, don't do all those things, and patient cannot have that. So such patients also you have to take care of it, because patients who are taking insulin and not eating the food can also go into hypoglycemia, maybe after walking out of your clinic. So you need to make sure that patient has his food perfectly before the treatment and takes insulin also. See, the main problem is taking an insulin, not having a food, or not taking an insulin, having a food can go to hypoglycemia also. So as a general guideline, always make sure that a when controlled diabetic patient, routine treatment has to be done, routine meal has to be taken, and normal insulin has to be given. Everything is routine here. You make sure that you change any disharmony or mismatch of your treatment protocol, or you tell the patient that you have a surgery. The patient has always the intention that I have to undergo surgery, I should not eat and go. But that is not good for a dental treatment. For medical, it's a different thing when we ask the patient to go for nil by mouth. But here it doesn't happen. So please make sure that whenever you are referring a patient for surgery or appointing the patient for doing a surgery or an extraction, make sure that patient takes his or her regular medication and regular meal on time and come to your clinic, measure the glucose levels and go ahead. And you know that, suppose you know the treatment is very long, it may take 2-3 hours. You know it's a difficult impaction, or it's a difficult flap, or you may take you're doing 2 quadrants, or there's a regeneration case. Insulin dose before treatment may need to be reduced also, because there are more chances. Dietary restrictions will be there post-op also. So you have to make sure that. So if you're reducing insulin, make sure that patient goes on some oral hypoglycemic drugs. So consultations is absolutely prudent from a physician. They should have a treatment plan perfectly made. All the modifications have to pen down before doing a procedure. When oral surgery is indicated, it is usually best to limit the size of your surgical field so that patient can resume its diet normally post-operative. Otherwise, it is very difficult to resume the diet post-operative. Now we have got dental management of diabetic dental treatment. This is one of the snap which is taken from JADA. We have got hypoglycemia. What will you do? The assessment is important. Monitoring the blood glucose level is important, and avoiding the peak activity during the insulin half-life. And you have to measure or look into the blood glucose levels and timely administrations of carbohydrate source, which can be oral, IM, IV. Infection and delayed wound healing is also a problem. So you have to make sure that patient starts with antibiotic prior, post, and smoking inhibition and other things are there. Then also happens in few diabetic patients that potential complication for diabetes in a patient is also burning mouth syndrome, oral burning, and salivary gland dysfunction. Patient may have oral dehydration. Patient may have xerostomia. That is also happens. So you know that a diabetic patient can have a lot of issues. When you're managing a diabetic patient who is a dental patient, you need to look into the patient's mouth, because most of the diabetic patients will have xerostomia. Diabetic patients will have slow or a very very viscous saliva. They have a very poor response from the immunity, so they may have sometimes you may see a long-term immunosuppression. You may see a candidiasis in a patient's mouth. You may see a lot of infections in the mouth. You may also come across multiple abscesses in the mouth, especially for the periodontist. It's important to look into the multiple periodontal abscess, which can be seen in a diabetic patient, which is very common in diabetic patient. That is also a very important thing. So you need to consider all these things when I'm managing a diabetic patient. Now, you have a doubt what type of hypoglycemia or hypoglycemia clinical differences you may come across. So for an hypoglycemia, you have got patients who have got less than 60 milligram per deciliter. You can have shakiness, dizziness, sweating, hunger, headache, and all those things you can see on a slide. High glucose level, patient may always say, I'm very thirsty during the procedure. I feel the patient says, I have a urge of urination frequently. Patient may have a headache. So that is one of the most classic features. You can very clearly understand. Then when patient is hypoglycemic, patient feels sweating, dehydrated, pallor, irritable, and sleepiness. When patient is hyperglycemic, you see increased thirst, frequent urination sensation it is, headache, dry mouth, and blurred vision. So you need to be very, very clearly able to differentiate between hypoglycemia and hyperglycemia. But more than 75% of the time, we come across hypoglycemia, because if patient is hypoglycemia, mostly we do not do the treatment only because the prior evaluation will give us an indication about it. So, but you should be able to understand that. Then the most important thing will be here whether patient is having hypoglycemia or patient is having vasovagal syncope. So that difference you should be able to understand. That when patient is having glucose level alteration, patient's futures more or less match with vasovagal syncope, but positioning change and other sorts of cardiovascular issues are with vasovagal syncope. And patient is non-diabetic patient, then there most of the time it is hypoglycemia only. If diabetic patient goes to syncope, it is a hypoglycemic syncope. If a regular patient goes to syncope, then patient has not had his meal before, or it could be vasovagal because you have done a long-term treatment and patient falls the moment there is a orthostatic hypotension. So you have to be very careful on those type of patients and try to diagnose what best you can. Fine. Thank you so much for the presentation and your registration into your the webinar. And I would just conclude by saying that dental management for diabetic patient is very, very prudently to be addressed. Why? Because there are a lot of patients who are having diabetes, and you need to make sure that patients' medications are clear to you, physician's concern is clear to you, and you need to have the emergency care for such patients in your clinic in terms of oral carbs, Glucon-D, or an IV dextrose, or glucagon, and all, which you need to keep it in your clinic because it's a very common complication which you come across in your dental practice. This is something very, very important. Thank you.